and also here in Sierra Leone. Let me begin with a case study. Is a 62-year-old Caucasian male who has a previous history of excessive alcohol use. He drinks about a pint of alcohol on a daily basis. Pint in the United States is about 375 ml. He also uses indiscriminately recreational drugs, including fentanyl. He smokes excessively, and also he has chronic kidney disease. He has not seen a doctor in about 7 years.
No.
His social history is remarkable for being single, without a domestic partner, and actively, and he participates indiscriminately in unprotected sexual activities. He has no history of immunization. But he presented to our emergency department with his family because he had acute neurological changes, decrease in cognition, and he has been having weight loss, intractable nausea and vomiting, abdominal pain, increase in, and he has a problem having sexual activities. When we saw him, his vitals were remarkable. Blood pressure of 80/60, respiratory rate of 16, heart rate of 130 regular, SpO2 was 94% room. He appeared very unkempt, and his eyes were ecteric. His chest was clear to auscultation. Cardiovascular system, except the tachycardia he had. We listened to his heart carefully. He had a systolic ejection murmur at the apex of the heart, radiating to the accident. His abdomen was distended. There was shifting dullness with fluid thrones present. He has atrophy of his genitalia. He has bilateral peripheral edema.
Which slide do you want? You don't have to case study on. Okay.
And his skin, the hands, he had palmar erythema. He had spider angiomenta, had caput medusa. We did some labs. I had some aggressive residents I trained. They said, before we do this, check the PTI. His INR was 6, but the guy is dying. He's having pain. And I told them, well, why not reverse it? Because that can't wait. Anyway, they went and did a parasynthesis, removed 8 liters of xanthoprobic fluid. Also, basic labs were done, which is very essential in this presentation. Pertinent findings, I'm not going to go into things that are negative, but pertinent findings, he has thrombocytopenia. Platelet counts about 96. His hemoglobin was 7. His AST-ALT ratio was like 10:2. Alkaline phosphatase slightly elevated. His potassium was 1.2, magnesium 0.4. what can you do, ladies and gentlemen? If the patient like this present to you at Collins Hospital, what would you do? Okay. First, the disease itself. What we can do if the disease has to fall, and how we prevent the complication like having hepatocellular carcinoma.
Next one.
Anyway, but those of us who have studied some medicine, we know that there are stages in this situation here. First, we want to look at the etiology. Who gets the disease? And how do they get it? In the United States, we believe that African Americans are number one. And I believe in Sierra Leone, African Americans, Black people, males are more affected than women. Asians, people of poor economic status, that is, their annual income is less than $15,000 in Sierra Leone, very poor. Like I said earlier, there are things that we look at: excessive alcohol intake, hepatitis B and C from unprotected sexual activities for those who are very promiscuous, and also also we have other causes of the disease itself, which you may not be aware. Drugs. We give indiscriminately Tylenol to people. When you go above 4 grams a day, you are putting that person at risk. We give something like methotrexate, which is an anti-cancer drug, can also lead to a liver disease. Today in America, it's not alcohol that is the number one reason why people get cirrhosis of liver failure. Americans are living and they want to get legal. So we have non-alcoholic fatty liver, obesity, like Dr. Thank you, just like Dr. Patricia just talked about. We also have things like Wilson's disease, hemochromatosis, alpha-1 antitrypsin deficiency. All these things can cause that. But our reason of talking about this is the social impact that we have, lack of immunization, and people who get hepatitis B and C, and of course, the alcohol consumption in our country. We know that the first stage of the disease itself is an inflammatory process in which you have nodules that are formed, which is called steatosis, hepatitis. And then we go to, from the inflammation, nodular formation, decompensated liver failure, and compensated. So the thing is, the outpatient came to me, and as a primary care physician, you want to look at this situation and say, what can I do first? And we're going to talk about this in detail. We believe that the first thing you should do are initial labs. You do your complete blood count, what you're looking for, because if your liver is not working, you're not going to produce protein, you're not going to detoxify all these things you take and things like that. You're going to have thrombocytopenia, that is low platelet counts. You may come with anemia, because most of them start having GLP. And of course, those factors that protect us from bleeding are very diminished. Then I encourage people to do the liver function test. ALT, you usually find it in the liver. AST is also in the liver, but also in the kidneys. AST in this situation is not that specific. They will be both increased in liver disease. Albumin is produced, it's made in the liver. But somebody with a liver disease will have significant reduction in albumin. Alkaline phosphatase is produced in the bones, mainly in the bile duct. On your test, it will be normal or elevated. And of course, total bilirubin. Why is it jaundice? There's a blockage with production of the bilirubin. The liver is not able to clear the bile. So it's increased, and the patient will become jaundice. The gamma glutamine transferase, also found primarily in the liver, may be elevated. Like I said earlier, the international normal ratio is prolonged liver disease. So you have all of these things. Then you gotta think. You want to separate what you can fix from what you cannot fix. Next slide. We feel that you can do extra laboratory tests to exclude certain things. But before we go into this other test, there are common things that you're going to be affected, which are complications of this liver failure.
I sent me a link and said join. I'm trying to figure out what it's about. I'm sending a question, text to see what is. I'm literally typing what is this about.
Once we regularly see the hepatic encephalopathy, the other one, the GI people usually see esophageal varices, and then we see ascites. No. The guy's belly is big. You have dullness of proportion, shifting dullness, and this. We're going to learn how to look at this in separate. And my reason of presenting this is for those complications and how we can manage them. I see my resident tells me every time somebody comes, they say it's an alcoholic, has a neurological change. That's let's put ammonia level. Ammonia level is okay, but please don't follow it because there are zillions of their problems. Why? The ammonia level is elevated. We still do it, but don't rely on it until you have a neurological change. Because we have other things that can cause the ammonia level to go. For example, if the patient has urinary tract, for example, if the patient has a GI bleed, not all UTI can cause elevated ammonia levels. There are specific bacteria when they cause UTI, like the Proteus mirabilis, will increase ammonia level. So we keep this in mind. We're going to come to the point where we will take. But the other things we need to do to exclude some of these diseases or reasons why the patient has liver failure. If you're infected with hepatitis B, the surface antigen, IgM and anti-AP will be elevated or positive in acute hepatitis. If it is chronic one, the hepatitis B surface antigen in the presence of viremia will be elevated. Anti-smoke muscles antibody and nuclear antibodies will be positive if it's autoimmune hepatitis. Your ceruloplasmin is also going to be present if it is due to Wilson's disease. Then, if you have an iron level greater or it's elevated, the serum ferritin is greater, and the trans saturation is greater, you probably have leukomatosis. Of course, you have all these updated data. This slide you see here has 10 questions in the United States medical licensing exam. If you know it, you have 10 questions. And that's why we want to let people who are practicing to take standardized exam to look at it. They'll give you a case scenario and then tell you your ceruloplasmin is elevated. What is the cause of this? So you know your answer. Next slide, please. Now, how do we really diagnose the disease? Clinical diagnosis. Yes. I always tell my residents, in any disease that you think is especially something that will affect the patient, please get a serological treatment. So you do this biopsy. Biopsy will tell us whether it is a liver problem or we do an ultrasound. You look at the size of the liver, it's a big organ, and you will see it. Next slide. Earlier, I said we could have esophageal viruses,
Can you mute yourself, please?
Earlier, I said we have esophageal viruses, which is usually very fatal. You know, the patient comes to you with hemoptysis or hematinesis. And we know the end stage of the liver disease is going to be cellular cancer. So when you have that, 8% of those patients will progress to a cancer of the liver. And those sort of patients, we say the risk factor to develop hepatocellular cancer, if it is hepatitis B or C, it's also significantly elevated. And patients who are older than 55, and patients, the prothrombin activity is less than 75%, will progress to what we call hepatocellular cancer. But now, we have these esophageal viruses. And GI doctors here, I think, can look at banding of the viruses. Do we do that here? No. So what do? We wait for the patient to death. The next complications you're going to see with these people is they may all develop ascites. And it's not a question of developing ascites. It's what happened to the ascites if you get infected. Some of you may know what is it. What do you get if your ascites is infected? How do you call it? Spontaneous bacterial peritonitis, right? So we have that. But it's also easy to treat. If we know, if we have the know-how, we do biosynthesis. Some people say, when you remove the fluid, replenish it with albumin. I usually tell them, I'm not a GI physician to critical care. But I always discuss this with my GI fellows that albumin is short-lived, so you probably don't even give it to patient. Always try to make sure that patient has enough intravascular repletion of fluid, and probably that will be able to. But the man has infected ascites, which we call SP. You want to treat it after you tap it. And antibiotics, you know, I'm not going to go into details of that because I have short time. The other thing is, what do you do for these patients? And this is where we're here. We know that once you have liver disease, you must have annual vaccinations. You must have a B and C vaccination. You must have your Tdap. You must have your pneumococcal vaccine. You will do well. You will do well by stopping the disease progression. We now have medications to treat hepatitis B and C if you're only following what the doctors give. If you don't, then probably you're going to progress to the cellular carcinoma. Now, the other thing is, we want you to have your lifestyle modification, what you eat. The American College of Gastroenterology tells us that when you take a Mediterranean diet, I'm not a dietitian or Pastor Israel, but it's a diet that's full of vegetables, nuts and things like that, that will help you. And also not starting that can prevent the progression of the disease and low dose of aspirin. So those are good stuff.
Want me to go to that slide?
So we have that. The lifestyle modification was from disease progression. And then when we have converted pattern encephalopathy, which is a personality change mentality, there are certain things we do to prevent those things. I want to caution people when you see cases in the hospital by giving them PPIs. What would PPI do? PPI means proton pump inhibition. They will put the patient at risk of the fact getting SVP, and that can kill them. But we see it sometimes. But I just want you to be careful. I want to also caution you. Somebody told me, oh, the next day you saw our patient's blood pressure was 160/90. I said, what do you do? Oh, doctor, I gave it a bit of blockers. Because the beta blocker will decrease the blood pressure, the water bill, and you're fine. I said, yes, that's good. But the guy gave this person metropolol, 100 milligrams for 3 days, and the patient became now very unresponsive. So he had beta blocker toxicity. So you guys in medicine, if you are treating a patient with hepatic encephalopathy, and his blood pressure is bad, you give him beta blocker, he has beta blocker toxicity. How are you going to reverse it? If you don't reverse it, he's going to die, right? Can anyone tell me antidote? Yes? Nobody? Glucagon. It's also good for what? Glucagon is used for what? Huh? Yeah, if somebody got a sugar of 20 and you cannot get an IV or something to give a dextrose 50%, how do you want to be so good? But it's an antidote for beta blocker toxicity. Then the other guy said, oh, I gave another benzo. I said, why? Guys have seizures, DTs. He gave this benzo, and you can't wait to die. So the reason why I'm bringing this is you see that on the conduct. But what would you do? You don't wait until the guy dies, right? You want to reverse the benzo. How do you reverse that? Do we know? What's the antidote for benzo? It happens at the hospital, so you should know it. We say give them flumazenate, right? Or romazacon. That's what we do. So I am presenting this as number one, in case itself, how you get it, prevent your life, modify your lifestyle, drink less alcohol. If you want to have 2, 3 girlfriends, protect yourself from getting hepatitis B, C, which you don't think you should. And living alone as a domestic partner, you're increasing your chance to do drugs and other things. But please immunize your patients. Please talk to them to modify their lifestyle. Exercise, eat right, and please have a low threshold to refer these patients to specialists. So, take home message is the liver is kind to all of us, but we must be kind to the liver too. Because the liver detoxify more than 500 toxins on a daily basis. And now when you mess your liver up, it's not going to be able to detoxify things. So you're going to have nodular micronodular disease, end up in cirrhosis, end up in cancer of the liver. And we now know that when they diagnose with cancer of the liver, at 2 years, 25% of the people die. And at 5 years, 85% of people. So, I didn't want to go into the details of all of this, but I wanted you to know that we need some things to be done in our emergency room when patients come there. We don't just start IV fluids with people. We want to know what's going with them and correct these underlying things. You can save lives. Thank you. Question?
Thank you so much, Dr. Pierre. Any questions?
Dr. Pierre, looking ahead, what do you see as a most promising strategy in intervention for reducing the burden of cirrhosis in Africa, given the limited resources and healthcare infrastructure in many African countries and third world countries?
Excellent. As you know, I'm an advocate. Care. Australia, we cannot afford curative medicine. Even as great as we are in the United States, we cannot afford curative medicine. Prevention. The first thing you do, the man that drink too much alcohol, stop drinking. Because it's going to what? Destroy your liver. If the man is promiscuous, then you gotta be careful, right? So if you prevent yourself from getting Hep C, stop drinking a lot of alcohol. I'm a little bit overweight, so but I don't have a vaccination. But try to lose weight. And also, you try to look at the other causes that I told you. Limit intake of Tylenol, limit the intakes of check your methotrexate. Probably you're going to prevent these diseases and you may not have cirrhosis. So primary care, preventive medicine.
Thank you. One more question.
Thank you so much, Doug, for that brilliant presentation. We've heard that the liver is the largest internal organ, and it has so many functions. I'm glad you brought up so many of the different types of liver cirrhosis. But my question here is especially for female Sierra Leoneans or Africans. What can you tell us in regards to gallbladder diseases in relationship to liver cirrhosis?
Why?
Yeah. Also, I've heard people saying, well, the liver can regenerate because cells, the copper cells. But by drinking alcohol, you can destroy the copper cells. What are the chances that if somebody have a liver disease that is related to drinking alcohol and cirrhosis, that the liver can also regenerate? Thank you.
Excellent question. First of all, we know there is high incidence of patients with hepatic encephalopathy, liver disease, so have gallstones. And some people in the United States say always try to look at the gallstones remove it. If you don't remove it, what do you get? You get biliary tract cancer. So that's another thing. So we know there's a significant relationship between liver disease and gallstones. And those people probably need to have cholecystectomy in the near future once they are there. Yes, the liver regenerates. And if you do these things, like I said, low dose nystatin, those things like that, they'll regenerate. But if you keep drinking, believe me, they will not, and you're going to develop cancer with that. Thank you.
I have a question.
Thank you very much again, Dr. Pierre. Congratulations for a very good presentation. One aspect of the presentation I'd like to add my voice is the issue of risk factor mitigation, especially for the infectious cause of hepatitis B and C. And I'm sure Doctors Dr. Bell and Dr. Foka will align with me that at the moment, the seroprevalence of hepatitis B in Sierra Leone, which was made public a few months back, is 14.8. And that one is really high, coming from a country like Switzerland, where it's 0.05%. So I think that's the national call to action, which we at every forum or fora that we need to do, especially for this coming from the when we all are diasporas, so that at least we can mitigate this in terms of behavioral change, which is one of the greatest factors. Our greatest investment in Sierra Leone is primary health care, which is 80%. And now that we have got the life-saving care, we need to look at what is affecting the individual. And hepatitis B is really, as therefore, we have been seeing lots and lots of end-stage cirrhosis. So I think it's a national call to action, and we're very happy to join us in this behavioral change, especially at primary level of prevention. Thank you. Thank you. We have one more question in mind. Go ahead.
Yes, thank you, Dr. Senesi, for that. Actually, I'm piggybacking from your question, because since Hep B is the major cause of cirrhosis in developing countries, what is the vaccination rate? Because in the States, they've done an excellent job with hepatitis B vaccination, vaccinating babies as they're born. How is the vaccination rate and what is being done to improve it?
Yeah, thank you very much. And I think, yes, indeed, the vaccination rate is far from what we want it to be. But if you know the magnitude of the problem, then you know that we have to invest aggressively. Now that for the past 2 months, we know the magnitude of hepatitis B, 30.8%. I think all hands are on deck. From the Minister of Health, we've got a new director of disease prevention, and we are rolling out our strategic plans. So I think in the next couple of years, we are really going to be on top of the situation. But it is all hands on deck, especially in areas of primary prevention. We really need to go a bit more. Thank you.
And thank you very much. I just want to reiterate this, Mr. Minister. If we can concentrate on providing basic laboratory tools in our hospitals, this, rather than looking at infrastructure, where you have to treat all the things, believe me, our mortality and mobility will go down. So we are appealing to the ministry today. Come on CBC, come on LFTs, BNP machines should be available in every one of our hospitals. Like even our teaching hospitals. I mean, it's a shame when I walk to come on, there's nothing there. And we miss a lot of cases. Just point of view. Thank you.
Give a big hand of applause to the prayer. Thank you, guys. I think we have a total of 2 or 3 presentations, and that's the only thing that's between you and the delicious lunch that has been prepared for you guys here. So please bear with us. For the sake of time, we're going to try to proceed ahead. Obviously, I'm the next presenter. So again, good afternoon, guys. My name is Dr. Kwak Sharif, Vice Chair of Healthcare Australia. I currently work at the United States Veterans Administration as a hospital physician. It's equivalent to the 34 hospital, so it's a military hospital that I work with. And I know there's lots of other people here who are medical people. I'm going to try my best to make this a little bit less medical so you can relate to it. I mean, I chose hypertension as much as from a medicine standpoint for practicing physician. Some people might think this is a basic thing, it's not a big deal. And for non-medical people, they might think hypertension is not a big deal either. But this is, as much as hepatitis B and malaria and all this stuff, this is one of the biggest cardiovascular disease killer in the sub-region and Sierra Leone as a whole. In the US, obviously, hypertension is a big issue as well. So I want to just talk about some of the latest guidelines on hypertension. Next slide, please. So the objectives is just to talk about the definitions of and its prevalence of hypertension, and we talk about the new guidelines. The last guideline from JNC 7, which was in 2003, it took another close to 20 years. The next one was in 2017 from the American College of Cardiology, American Heart Association. And there's been subsequent reviews with the European Society of Hypertension and Cardiology as well. And the pathogenesis of hypertension, complications, why is it important to control blood pressure, diagnosis, evaluation, and management, pharmacological and non-pharmacological. I'm going to give credit to American College of Cardiology, American Heart Association, where most of my information and the new guidelines came from. So I'll give them credit for the stuff. The big question is, why is it important to control blood pressure? So it is so important to make sure you, especially anyone in Sierra Leone's context, anyone over the age of 20, that they at minimum once or twice a year they do check their blood pressure, because it does, if you don't have blood pressure and you don't even know about it and it's not controlled, it puts you a lot of risk for stroke prevention, which I know Connect is having a lot of these cases with stroke prevention. Ischemic cardiomyopathy is a big issue. Coronary artery disease, dementia, heart failure. There are multiple other reasons, but these are the top 3 with people with unchecked and uncontrolled blood pressure. Those people who know that they have hypertension and decrease their blood pressure just by 5 millimeters of mercury, they can have a decrease in the incidence of stroke by 34%. That's a huge reduction by just decreasing your blood pressure by 5 millimeters of mercury. And obviously those with ischemic cardiomyopathy could decrease that by 21%. So these are the most recent updated guidelines. So basically, for hypertension, you have to have blood pressure over 130/80 millimeters of mercury on 2 different occasions. And or on the first occasion, where the person has to have some end organ damage. So if you examine a patient with blood pressure, let's say 140/82 with LDH on the EKG, and I'm sure Dr. Kake will see that on his EKG machine in both.
and retinopathy or chronic renal failure. So these people, you can automatically diagnose them with hypertension. You don't need to wait. The other ones without end stage disease from the exams, you have to do it in 2 different occasions. And there are sometimes you have to do even a little bit more. Next. So this is the updated guidelines from the American College of Cardiology and Heart Association. It's the normal blood pressure. Most people are going to be shocked. Its systolic should be less than 120. Diastolic should be less than 80. The old guidelines, the systolic needs to be less than 140. And for some reason, I don't know why our European friends are still with the old guidelines. I mean, maybe the preference over there a little bit different, but the European society is still using the old guidelines. The US, we have changed the guidelines. So this is the 2017 ACC, American Heart Association guidelines. So if your blood pressure is between 120 to 129, you're considered to be elevated. And this is where you want to catch these people, where you can introduce lifestyle changes, weight loss, exercise, cutting down your salt. This is where you want to catch these people. So it's important to do screening. Because if you catch someone here, you educate them, they're not going to go to the other stages. So it's important to do screening early on. And obviously, stage 1 is 139 systolic and 80 to 90 diastolic. And stage 2 is 140 over 90. Next. So this is the a comparison between the old guidelines from the JNC7 from 2003 to the new guidelines from 2017. And like I said, the Europeans seem to be on this old guidelines. They have not switched yet. But I can tell you, even in the US, except you were in some progressive institutions, there are a lot of doctors that are still on top of the new guidelines. You'd be surprised. I mean, these have come out since 2017. Lots of people are not on top of it, except if you work in a system where certain guidelines and protocols are checked that these stuff should be maintained. Or you do continuous CMEs. If you don't do that, you're not going to know what the guidelines are. So obviously, the old guideline here, diagnosis of hypertension from it's 140 over 90, and obviously with the new guideline, it's systolic pressure of 130 over 80, it's supposed to be hypertension. Next. So globally, the prevalence of hypertension is increasing, and it's really interesting with US. Obviously, with all the money and availability of medications, 50% of the population is still not controlled with hypertension. So you can imagine what happens in a research challenged environment like Sierra Leone, where screening is a big issue, and sometimes access to certain medications is a big issue. Next. So Sierra Leone's case, I believe one of our colleagues here in 2023 did a literature review where 1 in 4 adults over the age of 50 who are living with hypertension had low awareness, which is expected. I mean, even in the US as well, adults still have low awareness. But I think that 25% here is much, much higher if you get a bigger group of people. So it's a big issue, and I think they are on the right track. Their recommendations was defining the need to do robust, comprehensive hypertension prevention, treatment, and control policies. So that's something that definitely, in a global aspect of management within the ministry, this needs to be addressed because it's so important to control blood pressure. Next. So this is just the pathogenesis of primary hypertension. There are multiple genetic and environmental factors. And these are the 3 common ones where you have an increase in intravascular fluid volume. And most of the time, some medications target this pathophysiology. Medications like thiazide diuretics and people who seem to be hypervolemic. These medications can have them excrete some of their extra fluids and help with extra blood pressure. Renal dysfunction is the issue. Vasoconstriction with increased total peripheral vascular resistance as part of the pathophysiology of hypertension as well. And obviously, this is some of the risk factors, fixed, moderate risk, and modifiable risk. And one thing I looked at here that's really interesting, secondhand smoking. And you might see an old lady in any village in Sierra Leone, you might think she doesn't smoke. And well, she's at risk. Why? Because we still cook with firewood. This woman has been cooking firewood for probably 15, 20 years. What happened to her with hypertension? What happened to her with COPD? What happened to her with cancers? So you might see these people very tiny, they don't look, they might have all the other risk factors, but this long-term exposure with secondhand smoking, just from firewood smoking is a big issue. And obviously, unhealthy diet, physical activities, obesity, male sex, increase in age, it's a risk factor as well. Next. So this is a rich stratification where they took about 9,500 patients, stratified them by age and sex. One of the most important part is if you are over the age of 65, you got about 60 to 70% chance of having hypertension. So if you might have been fine all along in your 20s, 30s, and 40s, the older you get in your 50s and 60s, you really have to stay on top of screening because you have over 60% chance that you might get hypertension, men more than women. Obviously, if you look at the old, the Europeans seem to be falling on this track here. So if you use the European model, they tend to catch a little bit of the patients. There's a lower percentage compared to, let's say, in the age between 55 and 64. For men, it's about 70%. In the European, it's 53%. Next. So this is one of the most common secondary hypertensions there. You have renal pericardial disease, neurovascular disease, primary aldosteronism, obstructive sleep apnea, alcohol, drugs and alcohol use. So what Dr. Pierre was talking about organic cirrhosis. So you're going to have those people with cirrhosis and hypertension, and it really becomes difficult to treat some of these people. And the uncommon presentation for secondary hypertension, these labeled here, although thyroid disease is quite common, but these examples seem to be quite common in exams. For whatever reason, they're good exam questions that come out here if you take any of the American exams, board exams. Next. So just brief talk about patient with primary aldosteronism. So if you have a patient that is on 2, 3, 4 medications for whatever reasons, they're not being controlled, you have to don't add the 4th medication or the 5th medication. Take a stop that there might be underlying, there might be secondary reasons for the hypertension. And most of these people tend to be secondary hypertension. And especially if you start with someone with resistant blood pressure, that when they're on thiazide diuretics, their potassium becomes very low. These are the people you want to definitely work up for primary aldosteronism. Obviously, recommendation for renal arteries stenosis is another issue here as well. There are common medications that people have. And some of the contraindications is patients who have bilateral renal artery stenosis, you cannot give them certain inhibitors because it could cause permanent kidney damage that could lead for them to be on dialysis. Next. Obstructive apnea is another problem. Someone who's tend to be moderately overweight with a BMI over maybe 35 to 40, very obese neck, tend to have risks for sleep apnea. So most of these people who you're treating with 3, 4, 5 medications, if you're not getting any improvement, you want to make sure you screen them for sleep apnea. So these are some of the complications we talked about earlier in regards to if you treat hypertension as controlled, you can prevent these comorbidities from this patient. Next. Hypertension quantitatively is the most prevalent modifiable risks to premature cardiovascular disease, more than smoking. See how bad hypertension is? You might think smoking is bad. It is bad, but hypertension is worse. So when you see someone outside smoking, don't look at them, don't get them by the eye, and you get hypertension. You probably was fasting, okay? So smoking is a big issue. Dyslipidemia and diabetes. Hypertension is even worse than dyslipidemia and diabetes. Next. And again, this is the screening diagnosis. We talk about this. Someone has a systolic over 130, diastolic 80 or more in 2 occasions at different times, or people with end organ damage with any of these, you could diagnose them with hypertension. And this is the diagnosis, the guidelines we looked at earlier. where if you have systolic less than 120, you have normal blood pressure, diastolic less than 80, normal blood pressure. If you have 120 to 129, you're considered to be elevated. When you're looking at this, you might think, oh, this is not a big deal. Let's go to the next one. So this is one of the biggest problems in that even in medicine, even with doctors, we don't know how to take proper blood pressure. We don't know how to take blood pressure. Even in the doctor's office, we don't know how to take proper blood pressure. When someone comes into your office from outside, they're there for screenings, you have to check their blood pressure. But when they come in, you need to give them at least 3 to 5 minutes for them to sit down before you check their pressure. Because if you don't wait for 3 to 5 minutes to check their pressure, it's gonna be high. And that doesn't mean they have hypertension, right? That's another big issue. If you don't use the right size of cuff, right? There are different sizes of cuff. If you could just look at someone, if they are a petite person, you could use a small adult blood pressure cuff. If you don't do that, their pressure is gonna high. And you have a variant of 5 to 50 millimeters of mercury that can elevate their blood pressure. And the person needs to be relaxed. They need to be sitting there with a back supported on the chair. And they can't cross their feet. And I can tell you, at one time I worked with one of the best medical facilities, Kaiser Permanente. My medical assistants, patients come in and they just measure the blood pressure and they talk to these patients while they measure the blood pressure. You should not do that. So even in the best institutions in the US, we don't do this stuff right either. So you can imagine this is a difficult thing to do. But you have to be conscious of what it is that you need to do so you can amend some of these problems here. Next. Next. So this is the arm circumference size. For someone with 22 to 26 centimeters, you need to use a small adult, subsequently 27 to 34 adult. So if you use an inappropriate cup size, that patient's blood pressure is going to be high. That doesn't mean they have high blood pressure. That just means the person who's checking it doesn't know what they're doing. Next. And obviously, these are the recommendations that out-of-office blood pressure measurements are recommended to confirm hypertension and to titrate lowering medication. So in most cases, when someone comes to their blood pressure is high, and they don't have any other risk factors, and you're kind of concerned, you're not quite sure, they will send them with ambulatory blood pressure machine. It's a 24-hour monitor that just monitors their blood pressure, and that captures, it measures blood pressure every hour over 24 hours. Even when they're sleeping, that information has more value than any of the information that you do at the office. And sometimes people know how to check blood pressure. If they check their blood pressure at home, sometimes that even have more value in the office than the office. Next. And there's an issue that led to regarding white coat syndrome or white coat hypertension versus marked hypertension. When someone will come to you, they say, "Doc, my blood pressure is fine. Anytime I come to you, pressure high." So either we go back to the medical assistant is not doing the pressure properly, or this person really does have white coat syndrome, literally, for 24 hours, and just see how their natural state is at home. And that will measure the blood pressure over 24 hours, and then they'll be able to get an accurate information. Next. And next. So this talks about the different types of hypertension. This is what I was talking about, white coat syndrome. The person at home, their blood pressure is fine. In the office or any medical facility, they have high blood pressure. And the reverse of that is the blood person have high blood pressure at home, and in the office, their blood pressure is fine. So at home, they come and say, "Doctor, my blood pressure is very high." When you check it, it's normal. So this is another person that you need to give a ambulatory blood pressure machine. You hook them up and then monitor them 24 hours. And then after that, you can decide to see if they fit the criteria for diagnosis of hypertension. Next. So this is just the framework of someone with hypertension. I mean, with either white coat syndrome versus marked hypertension. So if the blood pressure is 130 over 80, and you give them a child 3 months of lifestyle modification to suspend white coat syndrome, you give them a daytime ambulatory blood pressure monitoring. And if the blood pressure is less than 130 over 80, then you come here. You continue with the lifestyle modifications, annual blood pressure check, and then you could monitor to see if there's any progression with their blood pressure. And if it's not, that's fine. And the other case, you can still continue lifestyle modification, and based on the blood pressure, you could start them with blood pressure at that time, because the ambulatory blood pressure machine had diagnosed them, and it's easy to do that. Next. And this is another schematics that goes through going through patient with secondary hypertension. So most of the patients that have uncontrolled hypertension, so it's either adherence to the medication. That's number one. You have to get to make sure they are taking the medications. If they're not, by the time you add 2 and 3, see if there's other underlying reasons why they have hypertension, maybe like secondary hypertension. Next. And obviously, when you see a patient's good history, physical exam, these are some of the laboratory tests you want to do to capture any of the end organ damages. So someone you did an EKG, they have LDH, they have blood pressure is 130 over 80. I think you to have high blood pressure, so you need to start treatment. Next. And obviously, these are a list of common secondary hypertension and well. Next. So interventions. Next. So this is the key here. This is for me will be the take home. You want to capture those people early on with elevated blood pressure between 120 and 129. If you catch someone between 120 and 129 and you advise them on diet, I know say salon will put to Maggi sauce. So Maggi sauce they add back the cooking, and it's really a big issue. You need to limit the amount of sodium we add by food. Any diet that's rich in potassium, eating bananas, cantaloupes, that really helps. Weight loss helps. But this is when you want to really catch these people so you can have better intervention. Like we're talking about, it doesn't matter how rich that country is, prevention is the key. US, with all the money we have, we still have a lot of complications for hypertension. So it's not about the hospitals you have, the machines you have. These are the basic things you can do without any infrastructure. So if we have a robust system that focuses on prevention, you can have a better outcome than any European or American country. So this is important to do. So this is called the DASH diet. Now, patients who you advise them to make this difference, you could decrease just with lifestyle changes. You could decrease their blood pressure between 4 to 5 millimeters mercury. So if that person is on elevated blood pressure about, let's say 128 over 80, you minus 4 or 5, you don't bring it into a normal blood pressure already. And if they maintain that over the years, they're not going to have any problems at all. But if you don't do this part, it's going to be a big issue. I know medication, most doctors love to write prescription, and this takes too much time. This takes education. Education takes plenty of time. It's easy to just write a prescription, but this is the hard work where you have to take the time, educate the patient, send them to nutritionist or dietitian to make sure they adhere to this. The DASH diet, which is dietary approach to stopping hypertension. Diet and fruits and vegetables, whole grains, poultry, fish, low carbs, and have shown if you really adhere to that, you can bring your blood pressure down to about 11 millimeters mercury. There are no medication that decreases blood pressure more than 11. The average medication they do maybe about 7 to 10 millimeters mercury. So you see how nature by itself is a good blood pressure medication. So if you do some of this diet restriction, it can really make a difference. Next. And so this is just talked about all the things I just talked about. Next. And some of the non-pharmacological stuff with minimizing alcohol drinks and cigarette smoking and all this stuff. So next. And this is another schematics about so this is about things you do regarding weight loss and how much blood pressure you can decrease with weight loss, how much blood pressure you can decrease with healthy diet, how much blood pressure you can decrease if you decrease your sodium intake about 1,500 milligrams per deciliters, and increasing your diet rich in potassium. Next. Aerobic exercises and dynamic exercises, all this helps to decrease your blood pressure. Next. Now, the next part is the pharmacological therapy with hypertension. And I know medical practitioners, doctors, nurse practitioners, and we love to write prescription. We love to give medication. Okay. And the issue with medications, they're expensive and they have side effects. So if you can catch someone when you don't need to give them medications, then you save a whole lot of money than wait until they have end-stage hypertension with complications. So if you decide to give someone medication, like I said, the average medication would decrease your blood pressure between 7 to 10 milligrams mercury. The DASH diet plus lifestyle modification, it can give you more than 11. So this diet alone is even better than most of the average medication. If you decide to give someone medications, you have to think about these two things. Number one, the underlying diagnosis of that person, because certain medications are good for certain diagnosis. And obviously, these medications, people have comorbidities and medications do have side effects. So you cannot take it lightly. Medication is not water, it's not food. It has complications. So you have to think about before you start medication for this patient. Next. So this is all the basic medications that we treat with blood pressure. So I call it the A, B, C, D of diabetes, hypertension medication. For those who are in the medical field, the A stands for ACE inhibitors and ARBs, angiotensin blockers, beta blockers, calcium channel blockers, and diuretics. Now let's start with A. A is the ACE inhibitors and ARBs. Then what I said about before you give someone medication, you have to make sure to see what's the underlying disease they have. So if someone has hypertension, have diabetes, you want to start them with ACE inhibitors. Don't start them on diuretics. Start them on ACE inhibitors, and these are the updated guidelines as well. So someone who has diabetes, you should start them on ACE inhibitors or ARBs. Someone who has heart failure, you want to start them on that. Post-MI, heart attacks and stuff, you want to start them on that. And some of the biggest issue with this group of medications are cough. 30% of patients with ACE inhibitors tend to have cough. And when they do, you just switch them up to, patients will come and tell you, that makes me stop, anything I take out, I get cough. So you switch them to the ARBs when the ACE inhibitors are an issue. Obviously, with angioedema, when they are ACE 12, they're top 12, you should stop this group of medication and switch it to the other medication. And the B is for beta blockers. And beta blockers, this guideline has changed. It's someone, if you diagnose someone with hypertension without history of heart failure or post-MI, you can start them on beta blocker. Before we said this used to be a cross line. Beta blockers are not cross line anymore, except if they have heart failure or post-MI. And the two common ones that have shown benefits in mortality and morbidity is carvedilol and metoprolol in some of the studies that were shown. Obviously, these are some of the issues there with beta blocker. You decrease your blood pressure, it can increase potassium, and you lipid panel. When you start these medications on people, you gotta really pay attention to. You might not think these medications will increase your cholesterol. It does. And if you don't check it, you don't pay attention to it, you don't know it does anything. This person will, then the next thing you're doing, you're adding another cholesterol medication. So now they have one medication to the second medication. So you have to know the biochemistry of this medication to be cognizant about it before you just start. You might say, okay, let me switch the beta blocker to another medicine and say, let me just add a cholesterol medication. And calcium channel blockers, there are obviously two types of calcium channel blockers. You have the dihydroperidines. These are the most common ones, the nifedipine, amlodipine, and even phenolphine. And then the non-dihydroperidines are the cardizine and verapamil. And these medications usually are used to decrease the heart rate, especially like atrial flutter and atrial fibs. Diuretics, the D1, which are diuretics. HTC is hydrochlorothiazides, and then Lasix. This works in the ascending limb of the loop. Apparently, this is a loop diuretics. But because this is one of the most common drugs that is used in Sierra Leone as well, we have to pay attention. diuretics can increase your calcium, they can increase your uric acid. So if the person get gout, they complain about stopping, not stopping on diuretics, because it can even make the gout worse. So it's important that you know the pharmacology of this medication, or you have a robust pharmacy system. Like, doctors, we are not always good at medication, but we are the one that write the prescription. So if you have good friends who are pharmacists, they will help you out with some of the stuff. So these are some of the risks of using diuretics. Will increase your calcium, uric acid, lipid panel, and glucose. That may even exacerbate diabetes, or it can even sometimes cause diabetes. So you have to pay attention to these things. You might think these medicines don't cause diabetes. They do cause diabetes, but you have to pay attention to it. And obviously, the Lasix or furosemide loop calcium blocker. And it's very helpful if the person has problems with kidney stones. If someone has kidney stones, they have high blood pressure, the diuretics, especially the loop diuretics, are good. It will flush out, it would decrease the calcium accumulation in the urine and prevent calcium crystallizing and minimize kidney stones. But obviously, they can decrease your potassium, they can decrease your sodium, as well as can lead to gradual renal insufficiency. So there are lots of other blood pressure medication, but these are the most common group that is in the updated guidelines of medications that you need to start with. You can use any of these three, A, C, and D, to start treating someone with hypertension, except D. We don't use beta blockers anymore, except in exceptions of heart failure and Hosema. And I think that's it.
Thank you, Dr. Ford. Can we take a few questions? We still have 2 more presentations and 3 more presentations, so we want to fast track this. So I'm going to try to take at least 4 questions, just 4. Let me give the non-healthcare Sierra Leone people, please. If you're with healthcare Sierra Leone, be patient with me. I'm gonna give the microphone to the who are not part of the organization.
Thank you very much. As a practicing specialist cardiologist, I want to add to this because it's very close to my heart. High blood pressure, hypertension, even though we are overlooking it is the second cause of maternal mortality in the country as we speak. So everything we do for maternal mortality, we have to also look at the chronic causes of maternal mortality. And also, when we talk about intervention, my recent literature review findings was something that was a little bit shocking for me because we all give advice in the clinic: lower your salt, reduce alcohol intake, physical activity. Those types of intervention cannot give us the results we want. It should be context specific. So, for example, you cannot tell the farmer to increase his physical activity. No, the farmer is already doing a lot of physical activity. You tell the farmer to reduce smoking if you know that that subset of people are smokers. And for example, the ideology we have about smoking is male predominant activity. No, one of the findings is that even in the villages, women chew tobacco. So you tell them it's not just stop smoking tobacco. You target the female and you tell them stop chewing tobacco. You make it very specific. In the clinic, you tell them reduce the Maggi cubes from 3 to 2, not just reduce salt. Reduce 1 spoon of salt to half spoon of salt. I think I will stop here. Thank you.
Thank you. Good point. Just give me a few, let me take a few more questions. Yeah, let me take 1 man and I'll come back. I have to end up parity here.
Thank you very much. Good afternoon. This is a question, but it's not going for the shows. But maybe the government of other stakeholders among us all. The thing is, hypertension is the key factor disturbing the health of our people in Sierra Leone. But as a matter of fact that we are going very, very high in terms of hypertension, the screening point is not documented. I am just pretty sure that if hypertension documented, we are going to get a figure to tell me about for research purposes. It is more so because all of the they have documentation with which when a patient is going to the hospital, a patient is screened, and that is done in the triage. But whenever we are seeing patients, it is not part of the outpatient, especially seeing patients at the OPA, whereas patients are coming in to take a kind of quantification of all those coming in. So I'm kindly asking that when they are reviewing the health-related groups, we incorporate the area of the blood pressure. Because when we did the management and leadership training program sometime in 2019, we are deliberating on issues regarding this. That by 2030, we're expecting that some of these diseases that are not transferring from one person to another may supersede Sierra Leone. And therefore, if we are running towards that level now in 2024, I am pretty convinced that if ever we are quantifying now the number of blood pressure cases coming into our facilities, we'll be able to use that as a research purpose. Thank you very much.
Thank you, Dr. Usman. Yes.
Good afternoon, everyone. Thank you. Thank you all for your comments. I'm Dr. Yebuka. I'm currently managing the hospitals and rates program here in Sierra Leone, and we basically go to underserved communities and provide high quality care for free. So basically, it's been over 2 years now since we've been touring all over Sierra Leone, and hypertension continues to be a significant problem, especially in the adult population. But then there's something that really struck me. Majority of the patients that we see that present with hypertension following the clinical guidelines where they will properly diagnose, majority of them have a systolic blood pressure of over 160 and a diastolic blood pressure of over 110. But then there's another part to this. Majority of these patients with this respective blood pressures, they have no evidence of any end organ damage. And I remember I went to our Honorable Minister, Dr. Austin Demby, and I said, what is happening? Could the normal blood pressure for Africans be different? And I said this, I did my clinical practice in the US, and I also have the opportunity to work in Canada for a year. So I have never seen a white person, guys, please forgive me here, with a systolic blood pressure of 180, walking and talking, coming to the clinic. So could the normal blood pressure for Africans be different? One. Okay, and then another thing that I noticed was that this what happened specifically. There's a village in Podloko, Mafoki village, where we went and we identified blood pressure patients, and then we provided medication. And then 4 months later, we gave them about 2 months medication, and we went back again 4 months later. And then when we went, so the same people whom we had provided this medication, their high blood pressure actually got worse. And then we find out that once they took the first 2 months of free dose that we gave them, some of them did not even finish the first 2 months. But for those that actually finished, and once that finished, they don't have the money to buy. And then also, those that actually, those that did not finish it, as soon as the symptoms start, primarily is headache. So most of the patient population that we see, the most common symptoms that they presented with is headache. So once the headache, they started taking their blood pressure medications, and then the headache becomes better, they stop. So I think that it's okay for us to focus on the lifestyle modification to target primary prevention, but also more importantly, as a country, we really need to also target this population wherein we can provide medications to them for those whom hypertension has already been diagnosed, especially if there's in these remote places, and in order for us to prevent secondary complications.
Thank you.
Most of these are actually observed.
Let me just address part of the circumventing question she asked. I mean, control of hypertension is a difficult thing to do. It doesn't matter which country you are in the world, it's a difficult thing to do because they almost become an abstract thing. You have this person have blood pressure 180/94, they have no symptoms. And here you are, the medical person, you're telling them they need to be concerned about something that they don't feel. So it has to be a multiple approach, multiple people in the villages, the chiefs, everyone needs to be involved to, one, health literacy is important. They have to understand the importance of health literacy because it's difficult, they don't feel it. And it's just numbers you're telling them, they don't even understand the numbers. But the interesting thing is, it's sometimes I tell some of my patients, I say, literally, you have a grenade, you take the pin out, and you put it in your pocket. It's just a matter of time when it's gonna explode on you. I said, that's what hypertension is. And sometimes they get that part. And no symptoms. You have this grenade, the pin is down. One day you're gonna have a stroke or heart attack. But it's difficult. Adherence is the issue. People don't understand it. So health literacy is important. Next question, and possibly the last one. Last question.
One last question, I'll move on to the next presenter.
Thank you. This is just a comment and quickly, a question to the medics in this room. Let's not go too far. When was the last time you checked your blood pressure? When was the last time you checked your blood pressure? So let's not go to the villages. We did an outreach in our hospital. We did an outreach and we tested the blood pressure of some of the nurses. And 2 nurses had BPs of 220 to 110. And they were working, they were at work. And one of them was like, do you have any issues? And she was like, well, I feel a bit easy sometimes. I'm like, really? So my message to the leaders of hospitals in this room, you know, Dr. Kapua is here. What we did was we created a team of nurses and 1 doctor, and they're responsible for the staff of the hospital. And you have a window of time because I asked one of the nurses, like, you never check your blood pressure? I don't have time to do that. I come to work, I go home, I have to do ABCD, and I don't have a BP machine at home, obviously. So get a team together of nurses and maybe 1 or 2 doctors and have a window, a sick day. You don't have to create one, a completely new one. You could create a little corner in one of the offices where the nurses can feel free to come in and take their BP, take their blood sugar, have a glucometer, just the basics in that office, so that the nurses and the doctors can actually feel free to come in between and check their BP and check their blood sugar and also get advice. So that's my message to the leaders in this room. Thank you.
Thank you. Let's put our hands together for Dr. Fuad Sharif. Dr. Fuad Sharif, 1 wrap.
Thank you, guys. Thank you. So we have 3 more presentations.
Oh, no, I thought you were gonna give it a wrap before we call our next presenter. Is that your wrap?
No, I'm done. We call it next presenter.
So thank you very, very, very much. Yes. Next.
So guys, after our 3rd presentation, again, we have food waiting for you upstairs. I'm looking forward to eating upstairs. So our next presenter is Dr. Alaji Suleiman, who will be talking about air leak syndrome, emergencies in newborn. Good
afternoon, everyone. I promise I'll be very brief. I'll say 2 minutes and time limit. So my name is Dr. Suleiman Sano. I'm a gynecologist US for the past how many years. I come sometimes I work with Dr. Bell in India, and etc. Other experience sometimes in the past. Next slide. So my talk today will be on pulmonary air leak syndrome in the range and also. So first of all, I'll go through the basic diagram of human lung. The human lung has for too long. We have the right, the left lung. The right lung has three lobes, upper, middle, and lower. The left lung has two lobes, upper and lower. Yeah. When you're entering into your trachea, entrance into the airway, it goes to the right and left main bronchus, the bronchi, and the bronchioles, and endpoint with the alveoli, which is the air exchange point in the lung. Now, so and the reason actually I'm going through this is because of the fact that since 2007, in Sierra Leone, there have been a bunch of trachea-based units where they use CPAP. And as we know, one of the complications of the use of CPAP or any breathing machine is a pneumothorax. So, airless syndrome is could be divided into different forms. You have pneumothorax, pneumomediastinal, pneumopericardial, pulmonary interstitial emphysema, and subcutaneous emphysema. Next slide, please. So, so the first one is pneumothorax. Basically, this is an intersection of air into the pleural space. Because in some parts of babies who are born, and of course, if you have enough air circulation in the air space or in the pleural space of the lung, you have, of course, tension in the thorax. And of course, this can lead to severe cerebrovascular collapse, which I'll go over sometimes along the line. Now, there are certain factors that can predispose children or babies to actually pneumothorax, which include prematurity, delivery, pneumococcal, pneumoconstipation, mechanical ventilators, and fluid distress syndrome. Although sometimes it could be asymptomatic, but of course, typically it occurs worsening dyspnea, grunting, and cyanosis. You have the express sound on the side of the pneumothorax, and just from that side, you have the legs and chest. Now, how do you diagnose pneumothorax? Is actually any baby who is on a respiratory support, be it a CPAP or a ventilator, and you see a sudden deterioration in his respiratory syndrome, meaning that somebody was breathing like in the 60s, breathing at 100, then it has to be something you know what, it's a little bit pneumothorax. Or sometimes if I just looking at pneumothorax, you can do transillumination and with a carotid probe, and you see that side where it is, and with the probe. But the confirmed diagnosis is done by an X-ray, which we lack in some of the facilities here. So most likely you can diagnose here by looking at the clinical signs. Now, if you look at this diagram, this diagram here, so on X-ray, air actually is dark on X-ray, and fluid and it looks whitish. So this actually shows the pneumothorax in the left lung. And with the left pneumothorax, you see that the whole external structure, the trachea, the lung, the heart, have all been pushed to this side. This is called the intestinal shield. Now, this is very important in this to really recognize, because if you have this will have some consequences on the basic cardiopulmonary system. So what happens when you have this air accumulating in the chest wall and causing this shifting of the nutrients to the side, what happens is that blood going from other parts of the body coming into the heart actually gets minimized, can lead to hypotension and cardiovascular collapse. Next slide. Great. As I said in my previous slide, that some of the causes of pneumothorax would be any person which on the pressure support, either a CPAP or a ventilator. Next. Now, this is, I was saying in my previous slide that how you can diagnose pneumothorax by doing simulation. So it's like a pinpoint light which can point towards the chest. Now, in babies, on small babies, because they have a very thin chest wall, this is to see the whole area leak or well and leak because of the air in that area of the lung. Next slide. Now, this is the baby here, the 2-week-old with distress syndrome, actually, there was in my study, who had a left pneumothorax. Now, here is the air, here, and this is the normal lung. So you can see that the lung the mediastinum has been pushed towards the opposite side of the pneumothorax. And putting a chest tube, they're putting a left chest tube here. With the left chest tube in place, the air is gone, and of course, the left lung has again expanded to the chest wall. Next slide. Also of an aspiration. Now, sometimes babies who are distressed at delivery, they come in their bodies, in their fluid. By doing so, this sort of fluid can cause severe distress in the lung. We can call what we call the wall valve effect, which can make them to pneumothorax. This is a kiddo who has actually a right pneumothorax, and we are putting a chest tube, and the air is gone, and the right lung expanded, and the distress is less. Right? This is also a CTN, basically with a right pneumothorax. We have the chest tube, the air is gone, and the distress is less. And next. Good. So now how do you manage pneumothorax? Now, most people in pneumothorax actually resolve by themselves, Now, but if there is that intention in thorax, then that means evacuation of the air in the pleural cavity. Now, intention in pneumothorax can use small needle or angiograph in a syringe to relieve the air from the pleural space. Now, this is the diagram you are seeing. The butterfly needle and connected to the syringe by a stopcock. So basically, you put the needle in the chest wall. Usually, you go down the fourth and fifth intercostal space at the anterior axillary line, here, and then you put it there. Then you try to open this syringe, this stopcock, to let air from the chest wall into the syringe. When it's full, put it off, empty, and then connect back. Sometimes you do 3, 4 times of these. That's how the air is really there in the chest. So, maybe, even though this could be a temporary measure, with the actual treatment of pneumothorax is to put in a chest tube, 8% French chest tube, attached to a low intermittent shock. And also, after doing the chest tube, you have to do a follow-up, either auscultation, examination, or an X-ray to confirm that the tube is actually in good place and that it's functioning well. Again, it's said that what of babies who have pneumothorax actually can develop a system pulmonary hypertension. It's a big number of them, actually high level ICU, and this case is very, very sick. And they have to be ventilators, high level ventilators to really take care of them. So it's very important that those level of problem and because the skills the babies will have or require close monitoring not to get any infection like persistent pulmonary hypertension, which could be very deadly. Next slide. Now, this is one of the tools we use. This is a chest tube of different formats, This is what we use. So this is the chest tube. It's the 8 or 10 French test tube, but like trocar. Trocar is not needle-like instrument that controls the chest wall. And when you get into the chest wall, remove trocar, leave the chest tube in place, and then this is connected to the vacuum system, which helps pull the air out of the chest, the chest wall of the chest, so that the pneumothorax is relieved. Now, some of these can remain on this chest tube system for some time until the air in the lung is healed. Before you can remove and test tube, eventually get better. Now, consult the diagram of the deep aspiration of pneumothorax. Again, as I said, for those who are residents here, residents, so you go into the fourth and fifth intercostal space at the anterior axillary line and use a 5-inch needle and attach to it syringe through a stopcock. And the stopcock allows you to open and close system. You open the system, air flows from the chest wall to the syringe, put the syringe, empty the air, reconnect, open again, goes through. By doing so, able to save the baby. This is very, very life threatening. But sometimes, let's say, you don't have anybody on the staff who can at least put in the church to get the job continue on. A junior resident or a junior fellow, this is temporary measure you can put in place to doing that. But don't leave this tension here from there. The very common babies, very from everywhere, compromise, you will go into a new pulmonary job. That. Next slide. So this was years back. I was here at the authority from the residents. I was teaching them the importance of pneumothorax. I know because we are there on feedback. So I was showing them how to do transcrimination, how to identify pneumothorax, and if you are attending that out of review. So boom, at least you will temporarily relieve that pressure that here is long so that it doesn't die. So I was showing them how that is done. Where are these guys now? I'm sure they're out there in the country now. Next slide, please. So the next year this syndrome is called medicine. So basically it's the situation of air in the middle of the chest, extending the neck, and revealing the thorax to be medicine. It's within the default in about every 1,000 lifeback. However, this is not actually is. It's also does not for all the time, and the always cause symptoms. So you won't know it. Something very particular about pneumocystis, well known, but it's to be what is done in the US. I don't know what American the American College of Peace. But here in the US, we talk about the same time. So the same time, basically, for babies who have pneumocystis, we see an elevation of the stomach zone in the cell of the pneumocystis. You can see here. This lobe to be lying down. But if you have air here, the lobe is red. Now, pneumocystis actually usually block itself spontaneously. Next slide. Now, the other thing about pneumocystis is very important that, particularly here in the area of the neck. As you know, in the neck area, you have some major organs passing there. You have the vena coming in, you also have the major blood vessels, you have the trachea, you have the you have enough air in this area, in this very tight area, tight bony area. Of course, study. So just by very important, nice economic sign and to take the if needed. Next slide. The next biggie is a deep pericardium. So this is here we see the pericardium just on this. So at the heart case, if you have listening to that case during the heart case, unfortunately, you just follow the heart. There's study introduced of human pericardium. It has positive pressure ventilation, people or ventilator for have pericardium, or those who have plastic surgery or pericardial drainage, or those who have penetrating trauma in extent, or those who have some blunt trauma from eating in the chest, or those who have infection pericarditis with gas producing organism, or if it is to the form between the pericardium and adjacent air containing organ and the stomach or the stomach. Now, when you have the pericardium, some of the conclusion that it's called correct tamponade, because if you correct tamponade, what happens is that you have decreased venous system, you have hypertension and pericardial collapse, which actually kill somebody. And how do you treat new pericardium? By doing new pericardial synthesis. Next slide. This is a basic diagram of how we do pericarditis in babies who have pericardium. You can go either by the paratyphoid approach or paratonal approach. Use a syringe needle to go to the pericardial sac and try to drain the air from there. Of course, it's not done by our interventional physiologist or by a fellow to this area of physiology. So call them to have it done. And sometimes for maintaining to our experience, can we sweat? Or if someone who is die on you, they cannot show to save the baby, we can do that ourselves. Next slide. What I would call the other getting known is called pulmonary interstitial enzyme. So this is a collection of air outside of the normal air space of the pulmonary alveoli in the pulmonary interstitium. Basically, this is of air develops as a result of alveolar and terminal bronchial rupture. This leads to poor ventilation and oxygenation. Now, this happens to be big only on regular mechanical ventilation. You cannot be able to properly ventilate or oxygenate the baby. In that case, you really have to go to high frequency oscillator, like the high frequency ventilator or the high frequency jet ventilator. It is probably very, very bad for the baby. Next slide. Also have continuous anti-diamond. Any form of continuous or intermittent state air pressure can lead to this competition. Where we have air leaking from the chest to the lung, getting into everywhere in the below the chin, in the armpit, or over the shoulder. This will be very, very serious. So clearly, there has to be a function of baby. And in case of hearing, secondary to spectral rupture due to concentration. Sometimes because of creating a baby or a child or an infant, if it's done in experienced time, it can cause actually spectral rupture or spectral shock. This can carry high mobility and mortality due to the consequential side of tamponade, which will need aggressive therapy. In some cases, it will fall to ENT to repair spectral rupture, but the problem to be resolved. Next slide. Now, also, I got some slides also about also in the this is called nematodes intestinalis. It's here in the bowel of the wall. See this double appearance here? This is actually here into the bowel of this small baby. And this could be highly expensive of necrotizing enterocolitis. And this is severe bowel infection in babies. And sometimes you see them having bowel distension, vomiting, bloated stool, metabolic acidosis, and abnormal gas. And this will have a very high mortality, especially in the experienced, non-experienced hands. These are treated by emergency intervention by pediatric surgeons where they are available. Next slide. And also, as a consequence of the nephritic enterocolitis, we also have different intestinal operation like a portal vein gas. In this case, so you have here leaking from within the gastrointestinal area going into the liver around the portal vein, the liver. And this is also another sign of leakage here from within the bowel to the outside the bowel and in this during hepatitis enterocolitis, causing severe pneumoperitoneum and football side because it looks for another African football, but American football, but that boy this shape. Next slide. There was how we call as continuous intestinal operation. It's actually defined as a single bowel operation. Typical cause in the terminal area of some babies. It's a life-threatening condition that very low part of children, babies, and it's also by surgical intervention. Now, of course, but the reason I brought up this here is that actually the Young syndrome, if I know cerebral imagine of having these structural baby units now, we are in CPAP, and having this, knowing this problem, recognizing them, actually help, may help of these babies in case they have this complication. Thank you very much. Oh, right now.
Thank you guys. Anyone have a question? And please, let's have questions, not statements. Can we take 2 questions?
Questions? One going to. Okay. Who has a question? The concert.
Dr. Salom, what are the areas of research or innovation showed promising and advancing our understanding and management of pulmonary air leaks?
Next question. Well, of course, you know, we are young in Sierra Leone. I think we have to have a better diagnosis of this problem. Because as you can all understand, it will be very deadly. Because the baby has pneumothorax, and there's no way you can diagnose it, you will die. Now, thank God we have this SCBU, septic baby unit, where they use CPAP, which is very good. But one of the complications of a CPAP, or even a future who have ventilator, is that it can cause severe pressure in the baby's lungs and cause pneumothorax. Now, if it happens, how do you fix it? So, by showing the baby, put you on a bed, on a CPAP, within 14. But the way you're thinking about the consequences of this, of this intervention, so we have to know that by saving the baby's life, by putting down the breathing machine, that could lead the complication. Okay, prepare to fix it. It happens. So my colleague Dr. Ben and a team, and of course, who are available remotely, will go through this over and again. Thank God, I think now we have a freestanding children's hospital, again available remotely, can teach this procedure very easily, with possible better Wi-Fi. Mr. Minister, Dr. Minister, if they are available, that I have colleagues who actually we have a freestanding link between some countries in the Caribbean. We people volunteer to teach them free of charge. And I've been on the past 15 years. I have over thousand colleagues who are willing to teach free of charge, you know, just having necessarily a better way out who will do it.
Thank you, thank you, thank you. One last question going, oh, no, not gone. Thank you.
Thank you very much, Dr. Salam. I think what you're saying highlights some of the challenges in the practice of medicine in this part of the world. Often, I think we stress what you would call preventive measures and how infrastructure that is when they really need it may not be up to the task. And I think that's what the challenges we face. I think our approach should be, dual. Emphasize preventive medicine, but at the same time, improve the infrastructure and train people. Now, it's one thing to come every so often and highlight this. I mean, it makes us aware of what is possible. There's another thing to promote the establishment of, this technology, and I think we can do it. It's happening in other countries in West Africa. I think we should be thinking in those lines, along those lines. Thank you.
Thank you. Thank you. So, ladies and gentlemen, we only have 2 more presentations. Please indulge me. Can everyone stand up? Please, everyone stand up. Please indulge me. Stand up, let's stretch our back. We got 2 more presentations. Work those guts, so be ready to eat. We're gonna be eating after 2 presentations. So stretch and stretch and stretch and take nice deep breath, because I saw the minister fall asleep there. No, I'm just kidding, So, ladies and gentlemen, thank you for indulging me in the stretching. And we have lots of food upstairs to eat. We're gonna be presenting next. We have 2 more presentations left. I see Dr. Hensel is dancing, which is even better. She's working on those calories to add some more calories. That's good. The next speaker is Dr. Angela Dumbuya, and please give her a warm welcome.
Thank you. Angela is a nurse practitioner in oncology, which is the medicine of cancer.
Feel free to sit down if you can.
Which is the medicine of cancer. I've been an oncology nurse practitioner and I've been on 20 years. I work for the city of Boone. Okay, so today we're going to talk about prostate and breast cancer. This is going to be quick because we don't have enough time. So at the end, if you don't get it, just email me, I'll give you my slides. So next slide. So today we're going to talk about prostate and breast cancer. These are the objectives. We're going to define prostate and breast cancer. The statistics about prostate and breast cancer, which is In sub-Saharan Africa or in Sierra Leone, it is very, very difficult to get statistics on any of the cancers. We don't have a registry. If we do, it's not supported by the state or by the government. We should, this is one thing I hope the minister will take out of here, is we need to have a national cancer registry. Everywhere in the world keeps tabs on how many people are diagnosed with what cancer, what stage, and anything else. So we really need a cancer registry, because if you're trying to find statistics on cancer, you just don't have. Okay, so we talk about the risk factors, symptoms, diagnosis, and treatment. Next slide, please. So this is the first one, is prostate cancer. 1 in 7 men will be diagnosed with prostate cancer. It's just what's so the prostate is a sex gland in men. It is the size of a walnut, which means it's very small. It's responsible for producing fluid that sperm travel through it. It's located in front of the rectum and below the bladder. That's where you find the prostate. And it wraps around the urethra. Next slide, please. Okay, so this is a normal prostate. So this here would be prostate, that's the urethra, that's the bladder. This is an enlarged prostate. Just because it's enlarged doesn't mean you have prostate cancer. All it means is your prostate is enlarged, it's pushing up onto the bladder, it's making the urethra stretch in so you can't pee. So when you go use the restroom, the tinkle, much doesn't come out. So these are the people you wake up 10 times a night to go pee because you don't empty your bladder. The good thing about this, when you have it, you know, you have to go get it checked. So that's why most prostate cancer are diagnosed at a very early age. Because if you're a man and you have this, you're gonna go get it checked. This is a normal prostate. Right here is the prostate, that's the bladder, that's normal. That's cancer. That's prostate cancer. That's the bladder. Next slide, please. So in sub-Saharan Africa, prostate cancer is #1 for men. Around the world, lung cancer is #1 for men. But in sub-Saharan Africa, it's prostate cancer. We don't have really statistics in Sierra Leone, but I know a whole lot of men that have canceled, that have called me, that have reached out to me, that have prostate cancer. And most men in Africa, in Sierra Leone, when they're diagnosed with prostate cancer, it's stage 4. Most times, people should not be diagnosed with stage 4 prostate cancer. What do I mean by stage 4? Stage 1 is cancer that is just in the prostate. Stage 2, maybe it's gone to the lymph nodes around the prostate. Stage 3 is gone to the lymph nodes, more than 2 or 3 lymph nodes. Stage 4 prostate cancer is gone to the bones. That's where you see when men are diagnosed with stage 4 prostate cancer in this part of the world, they can't walk because it's affecting the spine, the lower spine. So that's where most men in this part of the world, when they're diagnosed with stage 4 prostate cancer, it's already spread outside of the prostate. Next slide, please. Okay, so this is just the statistics about prostate cancer in sub-Saharan Africa. It's more than 77,000 cases of prostate cancer in men in more than 40 countries in the continent. And you see, we have more men with prostate cancer in this part of the world. Next slide, please. So this is just cancer for men around the world. Lung cancer is always going to be #1 because of the incidence of smoking. Like everybody says here, smoking does a lot of damage to everything. And now in this part of the world, one of the things that's contributing to lung cancer is the generators. So we have to be very mindful of that, the smoke that comes with the generators. But smoking in this part and everywhere else, you see lung cancer. And then you have prostate cancer. Colorectal cancer is #3. That's cancer of the colon and the rectum. And then you have stomach cancer, liver cancer, like Dr. Pierre was saying, hepatitis and cirrhosis leads to liver cancer, which we call liver cancer. And then you have other types of cancer. Next slide, please. So this is the pathophysiology of prostate cancer. It means abnormal growth of cells in the prostate glands. You start with just one cell, it becomes abnormal, and then you have like 2 cells, 3, 4, and it becomes a round sticky tissue in the prostate. So when that happens, you get diagnosed via prostate cancer. So most of the cancer that's diagnosed in the prostate will be adenocarcinoma. So this is your majority of prostate cancer will be adenocarcinoma. That's just a type of prostate cancer. You have other ones like transitional carcinoma, sarcomas, neuroendocrine tumors. Those are all prostate cancer. But the great majority of men, when they're diagnosed with prostate cancer, will be adenocarcinoma. And adenocarcinomas are just cancers that start in glandular tissue that make mucus. So lung, liver, prostate, breast, colon. Most of those will be adenocarcinoma. Next slide, please. Okay, so the risk factor for prostate cancer, like I said, 1 in 7 men will develop prostate cancer in their life. If you take a biopsy of somebody, a man in their 90s when they die, chances are you will find small cells of prostate cancer in them. And age 60, okay, 60% will be over the age of 65. It happens in people younger than 65. It happens in people in their 40s and 50s, but most of the men will be diagnosed with prostate cancer age 65. Can you hear me better? So most of the men will be diagnosed with prostate cancer over the age of 65. Race, ethnicity, Black men. We used to, when I do prostate cancer screening in the US every September, we used to say this is a prostate cancer is cancer of West African men. It is really, really high in Black men. It's really high in West African male prostate cancer. So it's not something that we need to ignore. African American men, 64% are likely to get prostate cancer. It's very big. And the reason it can happen to most men if it happens. But in African American men, most of them were diagnosed with prostate cancer, it's late stage. And the reason for that, most men, and I'm telling you, a whole lot of men that are sitting in here would not come to me or to anybody to get your prostate examined, which is how we find prostate cancer, which is by doing blood work. And we have what we call DRE, digital rectal exam, where I take my finger and put it in your rectum and feel for your prostate. Most men are ashamed to do that. So if you are ashamed to do that, then by the time they find your prostate cancer, it's a stage 4. So family history, if your dad has prostate cancer, your risk of developing prostate cancer is higher. But the most important thing, if your brother has prostate cancer, the risk of you developing prostate cancer is higher. Gene changes, this is what we call genetic mutation. So all cancers start with a change in your genes. The genetic mutation, if a man has prostate cancer, you check for the genes, there is a BRCA. BRCA is just a breast cancer gene, which men can also have. If you have that genetic mutation, then the chances that somebody in your family has that genetic mutation and your risk for developing prostate cancer increases. Diet, increased level of vitamin D. I don't think we need to worry about vitamin D in this part of the world because we get it from sunlight. So we don't have to worry about that. Prostatitis, which is just inflammation of the prostate, can also lead to prostate cancer. Chemical exposure, we see a lot of people that were in Vietnam during the Agent Orange exposure in Vietnam. A lot of them are coming up with prostate cancer. So chemical exposure can also do that. Increased level of testosterone, where testosterone feeds prostate cancer. Most men, when they feel, okay, the sex drive is down, and they don't feel like doing that, they go check their testosterone. If it's low, they get injections to bring it up, which is good for somebody that doesn't have prostate cancer. But when you have prostate cancer, one of the things you need is to lower your testosterone level. Because testosterone, which is the male hormone, feeds prostate cancer. Next slide, please. And so these are clinical manifestations. In most cases, in prostate cancer, if you start having any of these symptoms, your cancer has already spread to other parts of the body. Because most times they don't even know they have prostate cancer. And sometimes it's incidental. You have a PSA done, or you have the blood work done, and the PSA is elevated, and then they find that you have prostate cancer. So if you have any of these, in most cases, it's already out of the prostate, it's already a stage 4, it's already spread. So clinical manifestations, slow urinary stream, so you go stand there to pee, and it just drop. So you have to do something about it. Hesitancy, you wanna go, but you don't go in. Incomplete emptying, you think you've already come out, but the next 5-10 minutes, you wanna go again. So the prostate is pushing up on the bladder, so you have to get that checked. Frequency, you're waking up too many times at night, or you're going too many times, just when you came back, you're going again. Edema in the lower extremities, and most of the time, it's the lymph nodes are involved, because the lymph nodes for the prostate will be here. So if you have a swelling in the legs, it means those lymph nodes are pushing on the legs. So that's why it causes that swelling in the leg. And then enlarged lymph node mental confusion. If you have mental confusion, you almost know that this prostate cancer is already in the brain. So you're going to have those confusions.
Under the Bluetooth.
Same thing. Impotence. This is the one side. Cancer. That's why sometimes I don't want to know. I don't want to know. Cancer. So the normal blood, the normal for prostate cancer PSA is less than 2.5. So when it's less than 2.5, you're happy, you come back again in 6 months or in 3 months, depending on what is being arranged between you and your urologist, or between you and your primary care physician. So when it's more than 4 nanograms per milliliter, your primary care physician becomes maybe concerned, or your urologist becomes concerned, and they say, wait, it's 4 points, more than 4 points. Let's test it again, let's take you back in maybe 3 months and do it again. But as long as it's more than 4, you have to keep an eye on it. DRE is digital rectal exam. So this is the one most men will do. Because all we have to do is put a glove in a finger, go through the prostate, and see you're looking for nodularities around the prostate. Is the right prostate equal to the left prostate? Is there anything surrounding those prostates? Is it swollen on one side? Can you see lymph nodes on? It's a very quick test, it's just uncomfortable. But what I tell men, we then have to go get a pap smear. So that's uncomfortable too, but we do it because we want to say cervical exam, cervical cancer, nobody wants that. So men, if it's approved, if it's here, if you can have it, digital rectal exam should be done at least once a year. And then of course biopsy. So you can't tell anybody they have prostate cancer until you do a biopsy. Because biopsy, you can't tell anybody they have cancer, period, until you do a biopsy. Because biopsy is one that tells you this person has cancer. It may look like cancer, but until you do a biopsy and get a result, it's not. You can't tell them you have a biopsy. And so you do a little core biopsy, and you can either do it with a ultrasound guided biopsy, and you have to do, for prostate cancer, you have to do 12 core biopsy. So what do I mean by 12 core biopsy? So the prostate is, like I showed you, is right prostate and left prostate. So you have to get 6 biopsies from one side and 6 biopsies from the other side. So you go in with a needle and try to get tissue from one side 6 times on this side and 6 times on this side, because if you do one, you're going to miss it. So you have to do 6 on one side and 6 on the other side. to get an adequate sample of the whole prostate, so you can be able to tell this person has cancer or they don't have cancer. Even when we do 12 core biopsies, you may still miss it, but the 12 core biopsy can help. So then the Gleason score. So the Gleason score is when you take the prostate tissue, you look at it under the microscope. So for every part of our body, the cells are different. The brain cell is different from the breast cell. The liver cell is going to be different from the pancreatic cell. The bone cell is going to be different. So all the cells in your body are different cells. So when you look at prostate cancer cell under the microscope, 2 to 4, what does that tell you? 2 to 4. When it's 2 to 4, it means those cells that I'm looking at under the microscope look exactly like prostate cells. They look like the prostate cells. So those people do well. If they look under the microscope, they tell you have a Gleason score of 2 to 4. It means it's less aggressive. It looks exactly like the prostate. So you go to a Gleason score of 7 to 10. Gleason score 7 to 10. You look at the prostate under the microscope, it doesn't look anything like the prostate. You look at those prostate cancer cells under the microscope, they don't look anything like the prostate. They look different. So those are very aggressive form of prostate cancer. So those people may or may not do well. And clinically, researchally, they don't do well because it's very aggressive. And then you have the ones that are within this group, which is hard to pick. They are in the middle. They may do well, they may not do well. They may do well, they don't smoke, they're not heavy, they don't have other comorbidities. They may not do well, you smoke, you heavy, you have other comorbidities. So that's the Gleason score. So most men, when you diagnose, if they're diagnosed with prostate cancer, this is where most people want to be, but this is where most people will be, between 5 to 7. The ones that are on here, they don't do well. Next slide, please. Okay, so genetic testing, most times if somebody comes in the practice and we is diagnosed with late stage prostate cancer, we have to do genetic testing to see. Because if you diagnose with stage 4 prostate cancer, it can be very aggressive. So we want to know, is this something that you inherited from your mom or your dad? That's what genetic testing is, because we all carry half of our parents' genes. I have 20-something, 23 from my mom, 23 from my dad. So if I have, let's say it's breast cancer, I have breast cancer, and it's very aggressive, I want to know, is this genetically linked? So I can be able to inform my children about it. So if I do the genetic testing and they say, okay, yes, you have the genes that causes breast cancer, then I'm going to tell my 4 kids to go to genetic testing. So we do that. And then we do MRI. This is just to look at the prostate and assess the lymph nodes that are involved and assess the bladder wall. Because remember now, the prostate sits below the bladder. And you want to know if something is your prostate cancer gone to the bladder, so you want to assess that. First CT scan, we do that to just check and make sure if you come to us and you have prostate cancer diagnosed, but you have back pain, you can't walk, then we do a PET scan. So the PET scan tells us is the prostate cancer anywhere else in the body, because the treatment is going to be so different. And then bone scan, because most prostate cancer, the first place they go outside of the prostate is the bones. And the ribs, the spine, the ribs, so those areas. So we do a bone scan to just make sure before we say this is what we're going to treat you with, one of those cancer just into the prostate, or is it outside of the prostate? That's what we do. Next slide, please. So treatment observation. Remember when I said if your Gleason score is between 2 to 4, it's very low. It's not very aggressive. So before we say, okay, let me just give an example. A 90-year-old man comes into the clinic and has a biopsy done, but the PSA was high, had a biopsy done, and they find maybe two of the 12 biopsies came back to be prostate cancer. But the Gleason score was very low, like 2. And he's 90, all he wants is, I don't want treatment, I don't want surgery, I don't want anything, so let's hurry up and let's do this. So then we just put them on observation. We see them every 6 months and just check. Surgery, depending on the age, most younger men, they want to do surgery. Because remember now, when you do surgery, robotic laparoscopy, prostatectomy, is removal of the whole prostate. It has a whole lot of complications. It extends your life. but then you have to deal with a whole lot of incidents. Impotence is the big one. Erectile dysfunction is another one. A whole lot of other issues. And then radiation is another one that we do. It depends on what you want to do. You can do radiation. Next slide, please. And cryotherapy is just freezing of the prostate gland. Of course, chemotherapy, but hormonal therapy is to try to reduce the level of testosterone. You can do that by having castration of the testicles, which nobody's going to do, or you can get hormonal therapy. And then, of course, chemotherapy is like when it's spread outside of the prostate, most of the time it's chemotherapy. And of course, these are immunotherapy, targeted therapy. These are all things that are in the pipeline and things that are working for prostate cancer. Next slide, please. Of course, there's vaccine that we're also working on now with prostate cancer. Next slide, please. Okay, so breast cancer. 1 in 8 women will be diagnosed with breast cancer. 1 in 8. For breast cancer, it's #1. Of course, for women, this is now for women, we've done the men. So breast cancer is #1, and colorectal cancer alone. Next slide, please. And the risk factor age greater than 50, you have a family history of breast cancer, you have a first-degree history, you have a personal history of breast cancer, then your chances of getting it increases. Next slide, please. Risk factors, weight, people that are obese, age, the time when you have your first baby, if you wait until the age of 30-something, your chances of getting breast cancer increases. If you went through the changes late in life, your chances of getting breast cancer increases. If you have your period later than age 12 or 13, your chances of getting breast cancer increases. If you don't breastfeed your kids, your chances of getting breast cancer increases. Next slide, please. Alcohol, this is how much you drink. For women, we always say you save 4 drinks a week. Men, we say 5 drinks. You say smoking and hormone replacement therapy. These are all risks. Next slide, please. So prevention, exercise, alcohol in moderation, maintain a healthy weight. Know your BMI, your height and your weight. BMI of 25 for all of us should be the goal. Greater than 25, you're obese. You're overweight. Greater than 30, you're obese. Okay, next slide, please. Also screening for mammogram is breast exam. Mammogram is the key. Mammogram is the gold standard. Okay, next slide. Okay, like I said, mammogram is an X-ray. You find just it has small radiation in the NCI recommend women age 40 to do mammogram. It decreases mortality death by 25 to 30%. Next slide, please. These are breast exams. Clinical breast exams when you consider my officer examine your breast. Self-breast exam is when you do your own breast exam once a month. Clinical breast you go do every 6 months. You go to somebody that does breast exam. Breast yourself you can do once a month. Next slide, please. Next slide. These are just a screening, MRIs, BRCA. Next slide. These are the types of breast cancer. So DCIS is what we call breast cancer, and this is invasive metastatic means it's already spread. You have people that can see their breast cancer during pregnancy. It's very complicated when you have breast cancer during pregnancy. I've seen a lot of women terminate their pregnancy when they have been diagnosed with you don't want to talk about it anymore. Let's go to the next slide. And so these are just the way you treat it. Sometimes it's just hormonal therapy, just a pill. Sometimes it's just radiation you have to do. You have surgery done. You can take the lymph node out. You can take the lump out of the breast, or you can take the whole breast out. So what I see in Sierra Leone is everybody that has called me for consultation about breast cancer is to remove the whole breast. Sometimes that's not necessary. Because if you remove the whole breast, or you take the lump out and get radiation. Well, I can see why Sierra Leone will take the whole breast, but there's no radiation facility in the state. Am I right? I don't think there's any radiation facility in the country. So most times they choose to get the whole breast out. But if there was radiation, you could just take the lump out, have radiation, have a pill of chemotherapy, and your chances of survival are just the next slide, please. So treating, this guy is just treating breast cancer, you do lumpectomy, and then you do radiation, or if you do mastectomy, you don't do anything. Next slide, please. And then endocrine therapy, well, not everybody's breast cancer is gonna be different. The characteristics are gonna be different. Is it fed by estrogen? Is it not fed by estrogen? And so that's how we determine what do we treat you with based on the characteristics of your cancer. Next slide, please. Invasive means already out of the basement membrane. It's out. So it's like a ring. It's already busted out and gone somewhere else. So that's invasive. So those ones have to be treated either through chemotherapy, radiation therapy, surgery, or combination of all three. Next slide, please. So they are what we call preoperative chemotherapy. So somebody comes in, the breast cancer this big, and I'm saying it this big in the breast. We just don't go say, okay, let's take it out. We have to shrink it with chemotherapy, and then we take it out, and then we do radiation, something. So that's what we call preoperative chemotherapy. Next slide, please. And these are the ones these are, I can give you the slides, so this is gonna take me longer to go, but it's a hormone that everybody has, acute breast cancer. If it's not treated, it can be very aggressive. It can make the cancer go to the brain, which nobody wants, or it can go to other areas, and chances of it coming back is very high. Next slide, please. This is just a test that we do to see not everybody that has breast cancer is going to need chemotherapy. So we do this test based on where you are with this test. Either you need chemo or we don't give you chemo. Next slide, please. And of course, chemotherapy, when you have surgery done, we give you chemotherapy. It depends on the type of chemotherapy we give you. It depends on the type of breast cancer that you have. So nobody is going to have the same type of chemotherapy. Next slide, please. Okay, so this is cancer that has spread to other parts of the body. It's out of the breast now. It's in the bones, it's in the brain, it's in the liver, it's in the lungs. So we treat them differently. Next slide, please. It's the same thing. Next slide. 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 I'm sorry. This is cancer that has treating breast cancer during pregnancy. It's not very common, but you have a whole lot of people that have breast cancer and treating them. If you want to know about this, just send me an email. I can send you that information. How you treat somebody that has breast cancer and they're pregnant. It's very short thing. Next slide. Next slide. Male breast cancer. 1% of men will get breast cancer. It's not a whole lot, but 1% of men, and I've seen a whole lot of them in my practice that have breast cancer. And we treat them just like we treat women that have gone through the changes to women that have gone through menopause. So that's how we treat men with breast cancer. Next slide. Next slide. Okay, that's my family. Next slide. I think I'm done. All right. So
All right, a couple of questions. So Dr. Dumbuya, Dr. Angela Dumbuya. We're gonna take 2 questions. The man is very much. Is it because it's breast cancer?
Thank you for the presentation. I work under the leadership of Dr. Bell for oncology work in Sierra Leone. So yes, we have cancer registry, and it's located in Connaught, and yes, it needs some funding and some other things. We pride ourselves saying that.
There. So I'll come back on prostate cancer presentation because I'm a surgeon specialist and also a urologist. So I see a lot of prostate cancer cases. There's one thing that is standing out is we now notice that, for example, prostate cancer is getting young. What I mean by this, before we used to see patients in the 70s, 80s, 90s, and like you said, but now, unfortunately, we see patients in the 50s and early 60s also with prostate cancer. And we've also noticed that patients with BRCA2 gains their prognosis is more worse. So these are the cases that we have. For the treatments, of course, there is no radiation therapy in country at the moment. So usually we opt for castration, and it's very difficult. Almost all of the men will not accept that. But then the hormonal therapy also that we give the patients, it's very much expensive. Currently, we have an injection which we can give, and that is about 2.5 million for one injection. And you have to take that every month. So we see that a lot of people do not opt for that. Most people do not even have the money. So these are some of the issues that we have. And I think maybe later we can also have a talk. You can engage with our oncologists at the kind of hospital and some of the other specialties. But I think there's a lot that needs to be done. Men, of course, we know the habit. You've said it all here. Most of them will not present early. The only time you see a man presenting or you test them for prostate related cases is mostly when they have retention, what we call blockage, semi-oncolonger blockage, daddy-longer blockage. So it's a very, very, very interesting discussion and topic that all of us will need to work on. But there's a lot that could be done to help in terms of treatment, in terms of getting all the needs, sensitization. I think we could work on all of that together to make sure we help our people. Thank you.
Thank you. Thank you. I have 2 questions, but I think I'm gonna give the Honorable Minister the opportunity to wrap this up.
Thank you very much, Madam Moderator. And thank you very much, Doctor, for a wonderful presentation. And just building upon the previous ones, I have a short question before I build upon it. You know, we want to reassure our colleagues that Africa in general and Sierra Leone in particular, we are really marching forward. You know, we have lots of factors in our favor. We have a younger population. In Switzerland, the average of median age is about late 40s or early 40s. In Sierra Leone, it's about 19 years. And coupled with that, the knowledge-seeking behavior of our health professionals, doctors, nurses, pharmacists, you name it, is really high. Even when I was out there, every other day you have police looking for postgraduate courses, engaged in online courses, because with internet, the world is like a global village. And so really, in terms of human capital development, in line with the vision of His Excellency President, I think the health sector and others are marching forward. And coupled with that, we at the ministry and countries whole, we have created an enabling environment. Because, you know, most of the gadgets we use, which as Dr. Pierre was saying, Connaught Hospital lack most of the basic things, it depends on energy. And so where we are marching forward with human capital development, we are well aware that we have, I repeat again, the sun in our favor. In Africa, we have the space. If you move around the country, you see lots of areas where you have solar farms. And most of our health facilities, including the tertiary hospitals, are being put on solar energy, including the Oladuri and the BCM and Connaught. So when we say we don't have the registry time, when we got it correct, and even around the country, within every 5 kilometer radius, we're going to have a peripheral health unit. About 2,000 of them are going to be solarized, which means that at least we have the solar energy. We can now think of the internet, you know, and just to reach that digital divide, that knowledge gap between the north and the south and the